अस्सलाम वालेकुम, मैं डॉक्टर ताहा हूँ। मैं यहाँ पर एक कंसल्टेंट rheumatologist हूँ. The topic of my presentation is gout, or the way I will begin is by a couple of cases, और उसके बाद I'll go into details of gout. So this is a typical 48-year-old gentleman who presented with pain, swelling, and redness of his first MTP joint of his right foot. और looking at his past medical history, ये hypertensive थे, ये medications ले रहे थे antihypertensive, जिनकी एक तो thiazide diuretic था और एक losartan. He was a smoker. He occasionally drank alcohol socially, and in his diet he enjoyed red meat. और family history इनकी कोई और family history नहीं थी. So this is his foot, and it shows redness, which is around the first MTP joint. लेकिन ये खाली joint पे नहीं है redness, it has spread all across the forefoot, which is common, which I'll tell you later. इनकी investigations पहले से हुई हुई थी. इनका जो complete blood count था वो normal था. CRP और ESR दोनों mildly elevated है. इनका uric acid जो है वो on the higher side था, but not higher than the range. In kidney function भी normal था, EGFR around 50 था और electrolytes unremarkable, ठीक थे बिल्कुल इनके. तो क्वेश्चन ये है यहाँ पर कि यहाँ पर डायग्नोसिस क्या था. तो डायग्नोसिस is he is a typical male. The site is typical first MTP joint, और इनके risk factors भी इसमें थे, which I would like to ask. तो अगर हम वो पोल कर लें, तो कोई भी इस पे within 30 seconds अगर जवाब दे दे. चले, I'll end the poll now. And अगर हम share कर लें इनके results को. हो गए तानिया share? जी मैं कर दूं. मेरे पास तो आ गए, सबके पास आ गए. ठीक है. तो इसमें जो कुछ चीजें हैं इन केस में, एक तो ये मेल है, तो that's a risk factor. Gout usually happens mostly in males. 9:1 का इसका रेशियो है. Second चीज जो है वो diuretic, that's also a true risk factor. Hydrochlorothiazide जो है can increase uric acid levels and can cause hyperuricemia and gout. Alcohol intake is also a risk factor. Losartan जो है वो actually is a mild uricosuric, so it actually protects you for gout. तो जिसने losartan mark किया and all of the above, so that's not that's basically the wrong answer. But being a male, hydrochlorothiazide and alcohol intake are positive risk factors. अच्छा, ये share results करने हैं अभी? ठीक है. जी, that's what I'm doing. So इसमें risk factors as I've mentioned, hypertension है, medicines, thiazide diuretic है, diet, red meat की diet हो या alcohol intake हो, ये सारे risk factors हैं. Caveat मैं इसका ये कहूँगी कि uric acid level ज़रूरी नहीं है कि abnormal हो at the time of an acute flare. So अगर वो high normal हो तो भी gout हो सकता है. अच्छा, it stopped again to move. अब सही है, ठीक है. अब second case है. This is a different case. इसमें खातून है. She's 67-year-old and she's had recurrent episodes of pain in her first MTP joint and swelling for 2 months intermittently. और अब वो आई हैं with swelling of the right wrist. और पहले कुछ महीने पहले इनकी एक दफ़ा left ankle भी swelling हो चुकी है. She is a typical lady. She's obese, hypertensive, diabetic. She's on an ACE inhibitor, furosemide, metformin, or social history. There's no alcohol intake, or she's a non-smoker, and she enjoys diet which is rich in red meat. This is not her photograph, but this is how her hand is presenting. The redness is not only on the wrist joint itself, but has actually spread into the entire hand. Looking at her closely, it looks like she has these soft swellings on her PIP joints and her DIP joint, and she has a boggy swelling on her elbow. तो इन खातून के और टेस्ट किए हैं, इसमें माइल्ड इन्फ्लामेटरी मार्कर्स जो हैं वो रेज्ड हैं, इनका CBC रीनल फंक्शन नॉर्मल है और इनका यूरिक एसिड भी हाई है एंड दिस इज अबव द नॉर्मल रेंज. बट इंटरेस्टिंगली इनका एक रूमेटॉइड फैक्टर भी किया हुआ था व्हिच वाज वीकली पॉजिटिव. Now in her case, she also has gout, but this is multi-articular gout. And the way we know कि यूरिक एसिड तो इनका यूरेट तो रेज है, लेकिन इनकी काफ़ी ज़्यादा और क्या कहते हैं रीजंस भी हैं. इनके टोफाई फॉर्मेशन हुई भी है and she's been probably suffering from gout for some time. By the time she's come to us, she has full tophaceous gout. In the two cases, male was younger and female is older, and that's how it happens with gout because the risk of gout increases with age. Now, the next thing is what I want to talk about is a summary of what I'm going to do throughout my talk. We'll talk about what is gout, who gets it and why, what joints are affected, what are the stages of gout, treatment कैसी होती है acute flare की, prevention किस तरह की जा सकती है, और I'll touch a little bit on the new treatments, but they're not massively used commonly, so I'm not going to go into it. And in the end, we'll talk about any questions you have. So gout, as we all know, is a disease of deposition of monosodium urate crystals in tissues, which are due to increased uric acid levels in the blood. It can manifest in different ways. Arthritis हो सकता है, tophi जो है soft tissue masses की तरह वो present कर सकते हैं, kidney stones हो सकते हैं या urate nephropathy. अच्छा, gout is very painful. And I think it's more painful than any other seronegative inflammatory arthropathy. It's easily treatable and preventable. And it is usually happens asymmetrically. Which joints are commonly affected? The most commonly affected joint, which happens in around 80% of the cases, is the first MTP joint of the foot. तो अगर कोई उसको podagra भी कहते हैं, अगर कोई first MTP joint pain or swelling के साथ आए, so the diagnosis is a lot of times just clinical. Other commonly affected joints are again the knee, the elbow, ankle, or least commonly affected joints are wrist, shoulder, and small joints of hands. ये जो least commonly affected joints हैं, ये उन लोगों में होते हैं जिनको established untreated gout होती है. Now, these are the stages. So the first stage is the high uric acid, which is asymptomatic hyperuricemia. At this time, there are no symptoms. This goes down into acute flares with joint inflammation. The gout goes into intercritical periods. Then you can see signs of advanced gout. So I would talk about the first thing, which is acute flare. Acute flare is तरह होता है कि pain again is severe, there's redness, warmth, swelling, and it's involved with disability that people can't walk. The flare usually gets to a maximum flare by 12 to 24 hours. Usually happens at night or early hours of the morning. Majority of the times is the lower extremity, and the first MTP joint is the most commonly affected joint. Signs of inflammation, जैसे मैंने पहले कहा है, खाली joint की नहीं होती बल्कि पूरे foot को या hand को involve कर लेती हैं. And you can have polyarticular pattern, which happens in less people, but it happens mostly in patients who have established untreated gout. अच्छा, intercritical period gout के लिए काफी important होता है. Basically what happens is you have a flare, then the inflammation goes down, and then you have this period जहाँ पर आपको कोई symptoms नहीं होंगे. Most of the time, this intercritical period जहाँ पर कोई symptoms नहीं होंगे can last for up to 2 years. और during this time, ये ज़रूरी नहीं है कि tophi deposit ना हो रहा हो. So tophi can still deposit during this time when there are no acute flares. इसके बाद जो है tophaceous gout हो जाती है. Now, capacious gout is where these soft solid uric acid deposits are formed on different areas of the body. Most commonly affected are your earlobe, आपके elbow पे हो सकते हैं, Achilles tendon पे हो सकते हैं. Usually these nodules are not tender or painful. मैं एक दो एग्जाम्पल्स तस्वीरें दिखाती हूँ. ये Achilles tendon पे है और नेक्स्ट वाला जो है वो एक किसी की फिंगर पे हुआ हुआ है. अब ये रिस्क फैक्टर्स के बारे में हम पहले भी बात कर चुके हैं and I'm talking about them again because these are quite important risk factors. Some of them are modifiable, others are non-modifiable. Non-modifiable में age होती है. Children don't get gout most of the time unless they have some disease which can cause hyperuricemia. Gender, male is to female का ratio 9:1 है. You can have certain ethnic people have it more, and it runs, there are some genetic variants. So if your dad has it, or then you may have the increased likelihood that you get it too. जो modifiable risk factors हैं वो तो metabolic syndrome के साथ आ जाते हैं. Obesity है, hypertension है, hyperlipidemia है, cardiovascular disease, diabetes, और dietary factors जो हैं उसमें आपका alcohol intake या high purine diet जो है, आप ये ज़रूर पूछें कि red meat ज़्यादा तो नहीं खाते. और फिर दूसरी बात ये है कि medications में thiazide या diuretics and थोड़ी सी और medications हैं which can cause increase your risk of gout. Little bit more on risk factors. So avoid food rich in purines, avoid alcohol, diuretics like thiazide should be changed to alternatives, try to lose weight, and overall healthy diet. अच्छा, diagnosis जो है वो अगर if it's the first MTP joint in a typical male, then it can be clinical. But the gold standard is if we can remove some synovial fluid and then look at it under a microscope, and microscope पे negatively birefringent needle-shaped crystals नजर आते हैं under polarized light microscopy. बाकी चीज़ें अगर डायग्नोसिस जो है हम श्योर नहीं हैं, जैसे कि डॉक्टर ज़फ़र बात कर रहे थे, अगर सीरो नेगेटिव इन्फ्लेमेटरी आर्थ्रोपैथी है और हम श्योर नहीं है कि ये गाउट है या कुछ और हो सकता है, तो एक्सरे, एमआरआई और अभी मैं अल्ट्रासाउंड के बारे में भी बात करूँगी, वो काफ़ी ज़्यादा हेल्पफुल हो जाता है. दिस इज़ जस्ट अ पिक्चर. अगर आपको फ्लूइड मिल गया है या आपने एस्पिरेट कर लिया है, नी के साथ कोई आया है, नी स्वेलिंग, एफ्यूजन, पेन के साथ, देन यू कैन लुक इट अंडर द माइक्रोस्कोप एंड इफ यू सी दीज नेगेटिव birefringent needle-shaped particles, and your diagnosis is confirmed. But there's a caveat to this. If somebody is unwell with fever, then they can have gout crystals along with infection or septic arthritis. So आप पेशेंट की क्लिनिकल हिस्ट्री जो है ना उसको ज़रा गौर से देखें. ज़रूरी नहीं कि क्रिस्टल्स मिल जाए तो गाउट ही होगी. You have to look at the full picture. You have to see how the patient is. कोई fever वगैरह तो नहीं है, कोई unwell ना हो, hemodynamically stable है, तो फिर उस हिसाब से आप फिर इनको treat करें. अल्ट्रासाउंड जो है वो आजकल काफ़ी ज़्यादा इस्तेमाल हो रहा है to diagnose gout. उसमें you have these specific features. It's mainly for the rheumatologist. You can look, you have this double contour sign, as well as you can see the tophi with the specified blackness, basically. We call it hyperechoic cloudy, which is surrounded by a hypoechoic border. But ultrasound can also help you with diagnosis in gout. This is just a photograph of an ultrasound. It shows the arrow is showing gouty tophi, and the arrowhead is showing the double contour sign. Now, the next level is how to treat it, basically. So this is just a simplified picture of how uric acid is formed and how can we treat it. Basically, purines get converted to uric acid, and xanthine oxidase inhibitors, which reduce the formation of uric acid, like allopurinol, act in between purines and uric acid. Then we can break down uric acid, or we can increase the excretion of uric acid. When the crystals deposit, this shows that how we can treat it, which I'll come to in a minute. So the first thing I want to talk about is how would we treat an acute flare. So first of all, we need to treat it as early as possible. And there are basically three ways to treat it. Either we can use anti-inflammatories. You can use Voltron with PPIs, or you can use colchicine, or you can use steroids. And steroids can be used orally, intramuscularly, IV, or you can give it in the joint itself. In severe flares or prolonged flares, we can use combinations as well. इस इन medication के अलावा जो है नॉन फार्माकोलॉजिकल मेजर्स भी इस्तेमाल हो सकते हैं, जिसमें जैसे कि रेस्ट करें, आइस लगाएं और पेशेंट को एजुकेट करें कि it can be treated and how to prevent it basically. Now, prevention. When do we think of starting the patients on urate lowering therapy? Agar attacks, two attack in 12 months, or if somebody is having prolonged first attack, I would start them on urate lowering therapy. अगर तोहफाएं हैं, chronic gouty arthritis है, joint damage है, या किसी का renal impairment है, diuretic therapy पर है, primary gout अगर young age पे start हो रही है. Now, the uric lowering therapy is basically divided into two. एक तो है कि आप decrease uric acid production, वो xanthine oxidase inhibitors से कर सकते हैं. The first one is allopurinol, is the first line, is the most commonly used. We can start at 100 milligrams per day and increase by 100 milligrams every month until target uric acid level is reached. Which is going to be 5 milligrams per deciliter, 300 micromoles per liter. Once we've reached this level and there are no more gouty attacks, then we can relax the level, the uric acid level. So that's the first medication we use. If people are intolerant of it, if patient is intolerant, allergy ho gayi, rash ho gaya, then the second option will be febuxostat, or uski dose jo hai wo 80 milligrams per day pe aap start kar sakte hain. Again, we have to wait for 4 weeks, repeat the uric acid level. If the target is not achieved, then we can increase it to 120 milligrams. Febuxostat has a box warning that it should not be given to patients with heart failure and if they have a lot of ischemic heart disease events. Although new studies are not sure if the association is correct, we still avoid it in those patients. Now, the second way of reducing the uric acid levels is to use uricosuric agents, and these are the three drugs: sulfenpyrazone, probenecid, and benzbromarone. Usually, जो है हम xanthine oxidase inhibitors को ही इस्तेमाल करते हैं, और ये अगर contraindications हो उनको तो इस पे start किया जाता है. अच्छा, अभी मैं एक poll करूंगी, and then I'll talk about it. So if we can do the second poll, please. So अगर इसका please जवाब दे दें. When should we start urate lowering therapy? During an acute flare, after the flare has resolved? चले मैं आप polling को end करती हूँ. Or so 20% have said during an acute flare and 80% have said after the flare has resolved. Historically, we've always started urate lowering therapy after the flare has resolved. पहले तो कुछ ये thought process था कि allopurinol can increase your risk of attacks. So, and the other thing is once your flare has resolved, the pain's gone, then you should start on allopurinol or any urate lowering therapy. So the correct answer over here is after the flare has resolved. ये हटा सकते हैं. I have another question to ask. Tanya, आप बताओगी. The second question is, should we stop urate lowering therapy during an acute flare? पोल अब रोक देते हैं results तानिया आप share करो. So most of you guys have written no, and I think that's the right answer. You do not stop the long-term urate lowering therapy during an acute flare. आप acute flare को treat करें, और अगर allopurinol patient है या febuxostat पे है या जिस भी medication पे है उसको continue करें. तो not stopping is the right way forward. Next, we can remove this. I think आप कर सकती हो, मैं कर सकती हूँ, मैं कर सकती हूँ. ठीक है. नहीं आगे नहीं जाना, फिर रुक गया. अब सही है. तो यही दो पॉइंट्स मैंने बात की थी. यूरिक एसिड लोअरिंग थेरेपी, we should not start a urate lowering therapy during an acute attack, and we should not stop it once an acute attack is happening. Allopurinol can increase the risk of gout in the first year. So some patients get recurrent attacks when allopurinol is started or febuxostat is started. And according to British Society of Rheumatology guidelines, हम colchicine in patients के साथ continue कर सकते हैं for up to 6 months. If there are any contraindications to colchicine या क्या कहते हैं patient tolerate नहीं कर सक रहा because of diarrhea, तो आप shorter period के लिए anti-inflammatories and PPI भी साथ दे सकते हैं. This is just a pictogram of how we should be treating gout. और basically अगर किसी को acute gout attack है तो I would say treat as early as possible. You can use either NSAID, colchicine, or steroid depending on the patient preferences. What are the contraindications? अगर किसी को renal impairment है तो NSAIDs वगैरह नहीं इस्तेमाल हो सकते. And then you can review them after 4 to 6 weeks and then give them education, advice, start them on a urate lowering therapy, or you can start them a bit earlier. Actually, I start them within a couple of weeks' time once a flare has resolved. So this is it. Another is about new treatments. Anakinra, which is not available in Pakistan, and senakinumab can be used to treat acute flares and gouts in patients who are resistant to conventional treatment. I'm not going into that because we're not universally using them as yet. Or that's the end of my presentation. Any questions? First question, which patient will need lifelong antihyperuricemic drugs and role of hydroxychloroquine in gout? So जिनको भी recurrent gout attacks हो रहे हैं जो है वो लाइफ लॉन्ग ही होगी. यहाँ पर थोड़े दिन के लिए ली जाती है और फिर स्टॉप कर दी जाती है. तो बेसिकली द ट्रीटमेंट इज स्टॉपिंग द प्रोडक्शन ऑफ द यूरिक एसिड. वंस यू स्टॉप द ट्रीटमेंट द यूरिक एसिड विल गो अप एंड क्या कहते हैं गाउट अटैक्स फिर होना शुरू हो जाएंगे. दूसरी बात ये रोल ऑफ हाइड्रोक्सीक्लोरोक्विन इन गाउट. आई डोंट यूज हाइड्रोक्सीक्लोरोक्विन इन गाउट एज सच. Do we have to treat hyperuricemia in acute kidney injury and best anti-gout medications? Now, acute kidney injury जो है उसको तो because you've written AKI as acute, so hopefully whatever the reason is, the acute kidney injury will get back to normal. Problem comes के जिनको chronic kidney disease होता है, अगर EGFR less than 10 है तो फिर हम थोड़ा सा मसले में आ जाते हैं कि कौन सी ट्रीटमेंट इस्तेमाल की जाए. क्योंकि एलोप्यूरिनॉल जो है एलोप्यूरिनॉल और फेबॉक्सस्टैट दोनों chronic kidney disease में मुश्किल से इस्तेमाल होती हैं. लेकिन even if your EGFR is around 20 or 30, I've spoken to lots of renal doctors and they say start slow on allopurinol, maybe 50, and increase it slowly. So we can still use allopurinol in patients with a chronic kidney disease. What is primary gout and secondary gout? Is there any relationship? Primary gout is because of आपका uric acid levels raised हैं, कोई और disease नहीं है आपको. Secondary gout जो है could be because of a reason. If somebody has leukemia और उसकी वजह से आपने treatment दी है, उसकी वजह से uric acid increase हो गया, उसकी वजह से gout हो गया हो. Any relationship of gout with menopause? Yes, there are certain hormones which are protective for the level of uric acid levels in your body. That's why males mein zyada hota hai, and after menopause, the risk in females also increases for gout. Is colchicine still being used for treating gout? Yes, it still can be used, and it's very effective. What are the lifestyle modifications of gout? It is associated with metabolic syndrome. So अगर आप weight loss करें और तो as with anything else it will help you. Secondly, आप अपनी diet का ख्याल रखें. Alcohol अगर कोई पीता हो तो beers वगैरह उसको stop करें. Red meat. So ये चीज़ें आप decrease करें. Can gouty tophi completely resolve with allopurinol? And not all of them. They can stop, but not completely resolve with allopurinol because whatever is deposited takes a long time to reduce. I think I'm running out of time. एक और recommend first line urate lowering therapy to consider. मैंने जैसे कहा है allopurinol is the first line. If it doesn't work, then or people have side effect to it, then we can start on febuxostat. Where synovial fluid aspiration is not available, can we diagnose gout on physical exam and clinical history? जी अगर जैसे मैंने first case बताया मेल है first MTP joint है उसमें तो आपको कुछ aspirate मिलेगा भी नहीं तो आप clinically कर सकते हैं लेकिन if there's somebody who's coming in with swelling of the knee is febrile, hypotensive, then I wouldn't diagnose them as gout. Thank you, Ji.